Hello all. Today I'm going to discuss something different. Drug Induced Sleep Endoscopy. So this 34-year-old gentleman who came with snoring and nose block. Initially he was referred for nose block and he did have deviated septum, but however he started mentioning about his snoring patterns. It was so bad that he could not lie down. He always slept in a sitting position or propped up position on a sofa. We did a sleep study and his AHI score was 34, very high. So we decided to go ahead with DISE, that is Drug Induced Sleep Endoscopy. So this video, which I'm going to play right now, is about the endoscopy. So this technique was developed in 1991 by Croft and Pringle. This is a flexible endoscope that we are passing in, and this is under local anesthesia. You can see this is in the sitting position. The whitish thing that you can see is the lignocaine spray. There is already overcrowding of the velum. His soft palate is quite bulky, and also his lateral area. Now remember, this is in the sitting position. You can see over here a lot of lingual tonsils. The base of tongue is also quite overcrowded. They are actually occupying almost all the space. He does have reflux changes over here. Then as we proceed, I did ask him to speak and we were assessing the whole area. The idea is to get a good view of the kind of elements which are swollen up, if I can put it in a layman term. And after this, the next thing we did was we made him lie down. He got very panicked, but the moment he got we put him to a sleeping position or a supine position, we saw certain change. We could see the area. Can you see this is getting narrowed? So the area has become very narrow. And the next thing that we did was we put him to sleep. We gave him propofol. That is the usual method. Initially people used to give midazolam, but midazolam has reported to have amnesia. Moment we put him to sleep, the whole area started constricting. This was a central or circumferential collapse. So we have different ways to assess. There are different classification. Pringle and Croft was, as they mentioned this procedure, their classification was one of them. And after that, there are numerous classification. VOTE, that is VOTE, has become popular over a period of time. At the end of the video, I have put different classifications and screenshot of them. A lot of secretions, and that was slightly unexpected because while going in there was hardly any secretion. Now that when we are putting him to sleep, we could see that this uvula, this is the uvula part, swollen. He's snoring. Okay, he is breathing, rather, if I can say. The moment it starts vibrating, you'll see that the person is snoring. Can you see that? The vibration, quite unique. And also see how the space gets narrowed. Hardly any space. Now this is in the sleeping position. No wonder he doesn't sleep in supine position. There's hardly any space. So this kind of patients, although if we give CPAP, they struggle. Now this person, his job is he travels a lot. So he cannot carry his CPAP machine everywhere. I'm placing the camera above the soft palate so that I get a good view that how it is collapsing. At this area, the soft palate, definitely the AP length has reduced. Hardly any space. I'm struggling to go inside with the endoscope. As I proceed, the base of tongue is also gone posteriorly. So these are kind of assessment we have to decide, and only depending on that. So here are the classifications, Pringle and Croft, as simple as it can be. The next one is VOTE classification that many people use it. There are different things that you can add on the classification. NOHL classification is another one, bit complex, but it can give you a detailed understanding. Bashar's classification is another one, just a scoring to understand the collapse pattern. And one more I would like to say is Woodson's classification. These are the various classifications, you can use any one. This will help us to plan surgery. Thank you for listening. Please do like, comment, and subscribe.